talk today about the pediatric ultrafiltration with the Aquadex device. Let me make sure I can get on the screen where I'm advancing. So I will be discussing on-label discussions, but there will also be some discussion about data in children who are under 20 kilos that are off-label. But do need to state that the smart flow system is indicated for continuous ultrafiltration for temporary up to 8 hours or extended longer than 8 hours in patients who require hospitalization use in adults and pediatric patients weighing 20 kilos or more whose fluid overload is unresponsive to medical management, including diuretics. And the presentation will be limited exclusively to on-label applications of the smart flow system, although I can't address any off-label questions. There are data in the literature in children that we've treated who are under 20 kilos. I'm not going to go through all of this because I promised Leah and Kelsey I'd be done in 45 minutes so that you all would have time for questions and answers. So we'll talk about ultrafiltration and pediatric patients in need of Aquadex. We'll spend a little bit of time on access options for children, and then some data on anticoagulation in children. But again, we'll leave time for questions and answers. These are my disclosures. The relevant one for this is that I do consult for Nuwellis, and I'm the Director of Clinical Strategy on a part-time consultative basis for them. Okay, so let's talk about fluid as a problem and the Aquadex as a solution for you. We do know that hypervolemia really is associated with poor outcomes in numerous pediatric cases. It's been demonstrated in pediatric heart surgery, greater than 10% fluid of accumulation after ICU admission, after surgery is associated with poor outcomes. We know about this in nephrotic syndrome, congestive heart failure, both in acute and chronic kidney disease, patients with solid or bone marrow transplants, sepsis, and in patients with severe burns. And, we've spent the last 20, 25 years talking about acute kidney injury, which is really important to identify patients who have decreased kidney function before they need dialysis or ultrafiltration. And I think that when we get to a point where we have such significant fluid overload, we really are dealing with acute renal failure at that point. So fluid overload, as I've mentioned, is associated with significant increases in mortality in children. It's very common, associated with morbidity and mortality in children. A study from the Prospective Pediatric CRT Registry Group, which we ran from 2001 to 2005 when I was in Houston, showed that for every 1% increase in fluid accumulation in a critically ill child who ultimately required CRT, there was a 3% increase in mortality. And that same study showed that getting to greater than 20% fluid overload was associated in a multivariate assessment with an 8.5 times increase in mortality. And when we're dealing with acute illness and acute renal failure, acute kidney injury, there are only a couple of things that we can currently do as clinicians in terms of supporting a patient. We can stop or reduce unnecessary nephrotoxic medications, and we can manage fluids and electrolytes. And we certainly want to try that with diuretics first, but when patients are diuretic resistant, we then need to think about escalating care to renal replacement therapy. And in a recent study that we completed with a number of centers looking at the Aquadex in children greater than 20 kilos. Fluid overload, again, was independently associated with increased hospital length of stay and mortality. And this was Michelle Starr led this, and this was the Ultra Peds registry, and this is currently under review. So the indications for children where it may be appropriate is persistent fluid overload despite escalating diuretics. And I do believe a patient deserves a trial of diuretics in almost every situation, but we have to really understand when we need to transition to escalating care, as I mentioned before, to renal replacement therapy. I think we've been hamstrung in the past of viewing these as competing priorities and what we really, or methodologies, and what we really need to think of them as is an escalation in care. We should start thinking like intensivists. We don't think of BiPAP and invasive mechanical ventilation as competing. We assess what the patient needs, and then we escalate and de-escalate care as necessary. And especially when volume overload contributes to respiratory support needs, patients have cardiorenal syndrome that impacts either their heart and or kidney function recovery. As I've mentioned, the post-cardiac surgery population is especially of interest because those patients have decreased renal perfusion, then they have decreased heart function, they undergo their cardiac slump, and we really do need to take care of them in a number of cases to prevent worsening fluid accumulation, which just then gets into a vicious cycle of abdominal compartment syndrome, increased afterload, and the inability of diuretics or the native kidney function to do its work, and the inability to maintain target fluid balance in a chronic patient setting. And I can tell you I've had a number of patients with chronic dialysis who have really been unable to maintain their adequate fluid status in the outpatient setting, and we were unable to get that fluid off in a 4-hour hemodialysis treatment. So we have admitted them to the hospital for Aquadex therapy. So these gaps in efficacy expose a major opportunity. And if we think about, in a standardized way, early identification of diuretic resistant patients and intervention in those patients who would benefit with ultrafiltration has the potential to change their course of care and their outcome. So again, it's indicated for continuous ultrafiltration therapy for up to 8 hours in a temporary mode or longer than 8 hours in patients who require hospitalization. It's approved in adults and pediatric patients weighing 20 kilos or more whose volume overload is unresponsive to medical management, including diuretics. So what are the benefits? Well, especially in a pediatric environment, it's safe. There's only a 35 mil volume of extracorporeal blood volume, so it allows for avoidance, hopefully, of hemodynamic instability that is associated with larger extracorporeal volumes. Non-invasive monitoring of hematocrit continuously supports titration and therapy decision-making at the point of care, and I'll show an example of that later. And it has a relatively low blood flow rate compared to other dialytic devices, going down to 10 mils per minute, all the way up to 40 mils per minute as a maximum. And this avoids hemodynamic stress. And newer version of the software, which is now being deployed, has ultrafiltration rates, intervals of 5 mils per hour to be more precise as you're going through the procedure. Again, it's gentle. It's an alternative when diuretics are insufficient or when intermittent hemodialysis cannot be tolerated and is therefore less efficient from a fluid removal standpoint, because you're always starting and stopping ultrafiltration, or you can't achieve in that 4-hour treatment the target dry weight. The filter alert in the machine helps extend filter life and reduce the treatment time. You can monitor venous oxygen saturation to guide oxygen delivery and therapy choices, and it automatically tracks the fluid removed through a gravimetric scale for greater accuracy versus manual methods or volumetric methods of a hemodialysis machine. So the key here is it's really predictable, precise removal of isotonic fluid, and can be achieved with a dual lumen hemocatheter, or in some situations, peripheral IVs, or a smaller catheter, which I'll discuss later. So just like with any dialytic therapy, blood is taken from the patient via the withdrawal line, as it's termed on Aquadex. The blood is pushed through the filter by the blood pump at 10 to 40 mils per minute. The ultrafiltration pump withdraws fluid across the filter using a negative membrane pressure. And again, there's a hematocrit sensor that monitors hematocrit 2.5 times per second, and then is able to look at the relative blood volume change during the treatment. The ultrafiltration pump can go anywhere from 0 to 500 mils of ultrafiltered fluid per hour, and then the ultrafiltered blood returns to the patient via the infusion line. And you can see the bag there again is on a gravimetric scale and is incredibly accurate, and can be, there's a valve at the bottom that can be opened to remove that fluid if you reach the bag limit. You don't have to, and actually don't change the bags as the treatment goes on. So again, in data in kids over 20 kilos, this was a retrospective study published in C. Jason. Shaina Menon was the first author. It was a 3-center study with us in Cincinnati, Shaina in Seattle, and David Ashkenazi from the University of Alabama. Children who were 20 kilos or greater, 32 patients, 107 circuits. The indication was volume overload in almost all of them. The most common mode was ultrafiltration, which is the approved mode. You will read about modified CVVH, which is off-label, but some patients in this study did receive that. And almost all patients, 97, survived a kidney replacement therapy discontinuation, and nearly 70% survived a hospital discharge. Importantly, there were no complications at the circuit initiation, which was observed. Again, this publication does include data on patients weighing less than 20 kilos, and I'll refer you to that to see how those patients did. And then again, in the UltraPeds registry, which is a prospective registry of patients who were greater than 20 kilos. There was also a retrospective component that included patients greater than 20 kilos and those less than 20 kilos. But in this prospective study, there were 91 children at 8 sites across the US. The diagnoses were congenital heart disease, end-stage kidney disease, and malignancy led to the 3 most common. Again, more than 90% of patients survived their Aquadex treatment course. And the way a treatment course was defined is that this was the number of procedures. So an Aquadex procedure, whether it was 8 hours or 24 hours, that was the unit of measurement for the procedure. A treatment course was for how many days the patient received those procedures and then stopped receiving Aquadex ultrafiltration and did not receive another treatment for the next 7 days. And of those hospitalized patients, many of whom, as you can see on the left, who were very sick, 2/3 survived to hospital discharge. And Kara Short, who's a very well published and known nurse practitioner in the nephrology section, has said for their babies born with diseased or absent kidneys, Aquadex has given them a chance at life because in the past there were no option to treat these patients. And again, a number of those patients are outside the indication, but you can go ahead and read about them in that publication. We expect, hopefully, that this publication will be available after reviews sometime in the second half of this year, but there are abstracts that are published that are available from the Cincinnati Children's meeting that we hosted last year here in September. Okay, so let's talk again about the patient populations. So every group is different, and so the question is how to think about what gaps need to be addressed with this really very safe and actually pretty simple technology. There are ICU patients who need fluid removal, but don't need the complexity of intermittent hemodialysis or CRT. If it's about fluid removal, and even can be used intermittently, which we have done many times here with a patient who's, say, on PERT with CRT or is on intermittent hemo, but we need maybe slower, gentler fluid removal, then we will intersperse an Aquadex ultrafiltration procedure in between those. And it can also be provide a bridge to de-escalation of AKI support. Maybe that patient is recovering kidney function, but they don't have enough urine output to not be able to go one day without some form of renal replacement therapy, but you'd actually like to see if their creatinine is improving, if you'd like a safe way to remove fluid without causing what Rinaldo Bellomo termed dialatrauma, causing the blood pressure to drop too low and causing more ischemia to recovering kidney. This can be an ideal therapy for you. So patients who have nephrotic syndrome, usually they have fluid accumulation and or acute kidney injury. And so albumin and diuretics aren't working. Patients with congenital heart disease, again, in the NICU, acute and chronic, that would be, not, there's no NICU patient that's over 20 kilos, but again, you can read about this. And then patients who have a stem cell transplant, bone marrow transplant, and VOD, this can it be a really, really good therapy to remove fluid and allow for continuous renal perfusion. The indications can be ultrafiltration alone. There are access challenges, ongoing or emerging concerns, again, with BMT and VOD. If those patients get abdominal compartment syndrome, that can compress renal arteries, lead to renal hypoperfusion. And there are no real true thresholds for initiation. It really is the patient in front of you. But again, you can have volume excess in the intravascular space, and then you have the hematocrit sensor to be able to help you guide this. It's usually continuous therapy, can often be intermittent. We tend to use it intermittently here, but other programs, especially in Alabama, will use it 24 hours continuously. We have done that here, but it's not our usual approach. It really depends on how this fits with your acute care nephrology program and the therapies you have. And you certainly can give albumin with ultrafiltration to be able to improve the oncotic pressure and help you remove fluid. I'm actually going to give you a few cases here that we published now almost 10 years ago. And Chuck Varnell is the first author. And this actually, this set of case reports of 5 patients, I'll be discussing just 3 of them, were really to demonstrate how we use the urinary biomarker NGAL, neutrophil gelatinase-associated lipocalin. But as we were going through these, I realized that we opted to use ultrafiltration with the Aquadex device in 3 out of 5 of these cases, and can really illustrate how the benefit of this therapy and not having to go to a more complicated therapy like hemodialysis or CRT for patients who just need volume removal. So the first case is a 14-year-old male, history of AML, who had a subsequent anthracycline-associated cardiomyopathy and had a heart transplant. He was admitted for decreased enteral intake. He had a low-grade fever, increased work of breathing, and low oxygen saturations. He went to the cath lab, had an episode of bradycardia that required chest compressions, and then he developed acute kidney injury with a FeNA of 0.05%. So clearly at this point had pre-renal physiology, functional AKI at least. Of course, we didn't know if he had damage-associated AKI. So now, taken directly from the paper, day 1, his creatinine was 0.88, BUN was 25. Creatinine on day 2 bumps a little bit, BUN bumps to 32. We put him on, and he had been fluid resuscitated with his arrest, and he already, while he was a heart transplant, we really wanted to try to keep him relatively euvolemic. So he had a 1.0 to 1.2 liter fluid restriction. We wanted to avoid negative fluid balance, and we decreased his home diuretics in this situation. But then his creatinine bumps, his BUN bumps, we did get an NGAL showing that he had some tubular damage. And at this point, he was pretty volume overloaded. So we did isolated ultrafiltration. He did not have a BUN or creatinine that really required hemodialysis at that point. Then his creatinine bumped again, and his BUN bumped again, and his NGAL bumped again. And so we certainly knew he was not going to recover kidney function rapidly. And so we were guided to do some more ultrafiltration here. Then day 5, his creatinine bumps a little more. We do hemodialysis because where his BUN was and his potassium was, his NGAL starts coming down. Then his creatinine came down, but again, he had been dialyzed, NGAL's coming down, and we did isolated ultrafiltration and a trial of furosemide and chlorothiazide. Did pretty well. We did another isolated ultrafiltration treatment because we really wanted to start to dry him out. So you can see in this situation, we were able to do 4 aquapheresis treatments. We only had 1 hemodialysis treatment because his BUN was rising, but we were able to really exquisitely manage his volume without causing any compromise in his kidney function or further damage to his kidneys. I'll tell you that NGAL is not dialyzed. It's 25,000 Dalton protein, and you can already see with ultrafiltration, as we're removing fluid, we're leading to associated with improved kidney function. And then again, you can see he's getting better here and doesn't need any more ultrafiltration. So what did this teach us? The FINA suggested functional AKI initially, the NGAL suggested structural AKI, and he received aquapheresis for fluid removal, knowing that this wasn't just functional AKI, but he didn't really have the indication for hemodialysis. And we were able to do this slower over a longer period of time than hemodialysis, and this was really safe for him. Okay, second patient has necrotizing fasciitis and acute kidney injury, 8-year-old with steroid-resistant nephrotic syndrome and relapse for several weeks, admitted for kidney biopsy, and he was symptomatic from his nephrotic syndrome. 2 days after his biopsy, he develops necrotizing fasciitis. He significantly fluid accumulated due to nephrotic syndrome, and he developed a supplemental oxygen requirement. He was then transferred to the ICU for further management. So what you see on the y-axis here on the left is the creatinine level. It was 1.48 on day 1, had exploration and debridement. On day 2, it bumped a little bit, and his NGAL was 2811. He had no response to Lasix. He was more volume overloaded. His creatinine's going up, but he didn't really need hemodialysis. So we did aquapheresis because he had no response to Lasix. Creatinine bumped a little bit, but we had taken a lot of fluid off him, and his NGAL's starting to come down. We did aquapheresis again, but we also tried Lasix as well, and he had a brisk response. So 2 aquapheresis treatments. Again, if this child had become more volume overloaded, I think his acute kidney injury would have worsened from abdominal compartment syndrome. And again, you can see after the aquapheresis treatments, we didn't cause any damage to his kidneys, and his kidney function really started to improve. He's transferred to the floor, and he's continuing with albumin and Lasix infusions. Kidney biopsy shows shockingly, and I'm being funny there, FSGS, but we held his cyclosporin treatment, which was our standard then because his creatinine remained high. His creatinine starts to rise again on the floor, and the team was unsure, is this related to his functional AKI secondary to nephrotic syndrome or FSGS, or if prolonged functional AKI has led to structural damage. This was clinically important to determine how aggressive to pursue diuresis for concern for adequate renal perfusion, or if he was going to need more intensive therapy. So again, on this is 5 days from the prior data, 5 days from when he left the ICU. His NGAL was above the threshold of limit, and then his creatinine continues to rise and his NGAL starts to come down. So, but on day 4 with the NGAL that was high, we pursued aquapheresis for 2 days. And on day 4 and day 5, And again, what I want to point out here is even though we were able to remove a significant amount of fluid for this patient, we did not cause any dialytrauma. We didn't cause any kidney damage. And you can start to see his creatinine continues to rise, but his NGAL's coming down. This predicted renal recovery prior to creatinine improvement. And so we didn't do aquapheresis there. But we did it for the previous 2 days, as I've mentioned, and we did not cause any dialytrauma or kidney dysfunction. And this is a really interesting case where aquapheresis absolutely was critical for this patient. So he was a 26-year-old male with Hunter syndrome who had a port for chronic enzyme infusions and an abdominal hernia that was healed with mesh placement, who developed sepsis and multi-organism infection of the port with the abdominal site. His weight on admission was 130 kilos, and then he was 140 kilos at the time that they consulted us in the ICU. He was there and left intubated after removal of the port and the mesh because he had, quote unquote, an impossible airway. He was receiving vancomycin for staph epidermidis bacteremia and pip tazo for strep anginosus growing from the mesh site. And then he develops stage 3, KDIGO stage 3, AKI, and he had oliguria. So here on the y-axis on the left, you have the creatinine in red, and on the green on the right, you have the urine NGAL concentrations in the green. Now, on day 1, this is before we were consulted. He was 3.2 liters positive. He was had worsening respiratory status, and the interpretation was this was really fluid. And then he gets another 3 liters positive, worsening respiratory status, worsening fluid. You see his creatinine going up, his NGAL goes up. This is when he goes to the OR for assessment and debridement, comes back intubated, and he's now 10 liters positive. His creatinine is 4.8. And the problem was he had a 7 French dual lumen standard CVC catheter. And this was a very, very large individual who was obese, who also now has 10 liters of fluid on him. And the surgeons every day were saying, do we need to take him back to the OR to put in a hemodialysis capable line? But we don't know if he will actually survive that because of how sick he is. And we said, well, let's try aquapheresis because we have this low blood flow and he's still making some urine, but clearly not enough. And so that's exactly what we did. And we were able in the first day, over 8 hours, to take 4 liters of fluid, 4 to 5 liters of fluid off of this patient. And he also did respond to some Lasix. Now you see his creatinine goes up, but that's because we are just uncovering the dilutional effect of all this volume overload. And then so the next day we take another 4 liters or so off, and with isolated ultrafiltration with the Aquadex, and he's having some diuresis. Creatinine still going up, but again, that's the same uncovering of the dilutional effect. And then he's back to his baseline. He's stable after being extubated. This was really, really a tough case. And even though his creatinine continues to rise, he then starts to improve later. And here's just what I want to show you. If you've been able to use non-invasive monitoring of hematocrit with intermittent hemodialysis, you know how valuable it can be. And this is from patient Michelle Starr took care of at Riley Children's in Indianapolis. But we had this same sort of sawtooth pattern with this patient. And you can increase the ultrafiltration and the hematocrit will rise, may hit the limit. And then you can stop or slow ultrafiltration and see the refilling as after it peaks. You can start to see the refilling where the hematocrit starts to be diluted. Each of the dashed lines are a threshold you can set on and move on the Aquadex device. So if the hematocrit hits that threshold, the device will automatically stop pulling fluid. It'll give you this notification, and you can change the thresholds throughout the treatment, or just as ultrafiltration stops, you can watch to see if there's refill. So this is a visual representation of blood volume change, which is inversely proportional to hematocrit change. If the slope is too steep, or if the threshold limit is reached, the ultrafiltration can be stopped to allow for refill in the intravascular space. If the threshold is reached and the patient is tolerating fluid removal, then you can make the decision to increase that threshold and do it safely. So, as I mentioned, each day surgery was on rounds, asking if he needed to go to the OR for cath placement. Despite a rising BUN and good urine output, as well as normal NGAL, gave us the confidence to recommend holding off on the line placement and using aquapheresis via the 7 French dual lumen catheter. He continued to do well and was transferred out of the ICU several days later. So what are the access options for pediatric patients? Well, you know these as well as I do. And the thing to remember, again, is that the maximum flow rate here for an Aquadex is 40 mils per minute, and the minimum is 10 mils per minute. So you often don't need as large a catheter as you would for somebody that you are running on CRT or intermittent hemodialysis to maintain it. I have not personally used peripheral IVs, but Kyle Merrill at the University of Iowa has. Obviously, it needs to be patient who has large enough to have adequate veins. But again, with this low blood flow, this is certainly a viable option to not have to put a central line in a patient. And then Nuelis does have a dual lumen extended length catheter, which is kind of in the middle. But again, you don't have to use 2 peripheral IVs, and it's not as big as most central venous hemodialysis catheter. So again, you have a number of different options, and you just have to match it to whatever is going to work in your institution, and if you have a vascular access team and nurses who put these things in, or if you need surgical access team. If there's a really nice guide in that Nuelis will provide that will give you a sense of potentially the right best option for a catheter for you based on the patient's hematocrit, what is the blood flow setting that you want, and what is the catheter rating. So again, in the A range is really where there's going to be a high probability of success because the catheter flow rating is higher. But in pediatric patients, we always have to match that with matching it to the vessel size and not causing venous occlusion, venous stenosis, etc. But your Nuelis rep can help you see how to use this guide to match what you may have in your stock in your Pyxis. We always have to think about the different process plans for access tree. I will just tell you, everything I do here is incredibly complicated, but the one thing we do is we've really standardized access, and we will go down to a 7 French dual lumen hemodialysis catheter for our patient population, even in the smallest ones. But you may have other options. And again, Kyle likes to use 2 peripheral IVs, obviously doesn't require surgical placement. And so that may be an option for you in certain patient populations. What about anticoagulation? We typically will use heparin here, and we will monitor ACT. You'll notice that the ACT we use here is with an iStat, and that's because ACTs don't really, the iStat doesn't really measure activated clotting time. It measures thrombin degradation. And so we've done the work here to compare that to standard ACT. You just want to add about 40 seconds, so 160 to 200 with standard ACT measures. Heparin is the most common agent. Sometimes people will ask, well, what about citrate? Can't you use citrate? The problem is you're not doing dialysis here, so the issue is you won't be removing the 40% of the citrate that we tend to remove with standard CRT dosing, so you'd have to be really careful. A number of programs, I know Nationwide Children's up in Columbus used bivalirudin for their, almost exclusively now for their anticoagulation for Aquadex, and we actually are getting their protocol so that we can try to stay away from heparin, again, in the smaller kids where we may be worried about bleeding. And low molecular weight heparin or DOACs can be used, but again, I don't think there's much in the way of pediatric data, so I'd be very, very careful with that. And these are things we tend not to use in children anyway, so I would certainly speak with people who have more experience with those. And those tend to be done on an outpatient basis anyway. Again, there are a number of different dosing strategies. Here's one that Michelle Starr again has used, as others. Typically, there's going to be a weight-based bolus and then a continuous infusion rate. You really do want to prime with heparinized saline because the heparin will actually bind to parts of the filter and decrease clotting. And then repriming according to your device alerts where the filter resistance is greater than 1. You can just use normal saline or other crystalloid if you'd like, but we tend to prime with heparin as noted here. Epoprostenol became very in vogue a couple of years ago, especially after the hurricane that wiped out the Vantive ACDA plant in Asheville, North Carolina. It is a pretty decent anticoagulant, especially for the short term. These are data from Dr. Naeem and Dr. Furman when Dr. Furman was at University of Pittsburgh. Epoprostenol is infused pre-filter via the withdrawal limb of the circuit using a dedicated pump. The initial infusion rate is 2 nanograms per kilo per minute. You can go up to 8 nanograms per kilo per minute without having the vasodilatory effects. And of the circuits that they used, about 240 of them in 46 patients, about 83% completed their intended course. And you can see over on the right, the weight ranges of patients, what was the primary reason for admission and where they were, and about a significant number of them were mechanically ventilated. So again, epoprostenol is certainly an option. Again, if it's going for more than 24 hours, the data suggests that may not work as well, but if you're using it for a more temporary course, it is something that we have used and it seems to work pretty well in the short term. Alternatives to anticoagulation, flushing and repriming. Again, I think if you're using this mostly in the short term for about 8 hours or so, you hopefully with a good heparin anticoagulation protocol or maybe a couple of the others that I've mentioned should be able to get through the procedure. But Riley Children's does have a nice saline flush protocol if you really want to stay away from any anticoagulation. The only important thing that you have to understand is as you're flushing, the Aquadex machine is not going to realize you're doing that. And so you have to add that ultrafiltration volume to what your target is. The other thing that's important is that if you do it quickly, you're going to acutely change the hematocrit, right? Because you'll be putting fluid into the intravascular space. So you may see a blip on the hematocrit monitor that you just have to be prepared for. So it'll look like the patient is becoming more dilute. So that's a kind of a brief overview of the system, and I did it in 40 minutes, so I stay out of Leah and Kelsey jail. Kelsey did not think I could do it, I have to say. I'm just going to out her right now. But anyway, I'm happy to take any questions. Thank you guys so much.
Does anyone have any questions? Question.
Yeah. A little bit.
There's a little table microphone. There's a microphone on each. If you press the button, then you're good.
I wasn't sure what NGAL you meant by NGAL.
Oh yeah, NGAL is a urinary biomarker, and it's approved in kids for the aid in the risk assessment of acute kidney injury. So a lot of times serum creatinine, it doesn't really differentiate between true tubular damage and just functional AKI from a patient being pre-renal. So think about it like a renal troponin, so it can aid to tell you, is this kidney function going to get better more quickly or not? So it was, it's been very helpful for us, but it really does also help us in thinking about, are we going to need to provide aquapheresis for a patient?
So we don't use NGAL here. So we use cystatin C. How is that in relation to the NGAL?
Cystatin C is another functional marker, but it's not a damage marker. So I think that you could still, you're not going to start any dialytic therapy based on a damaged biomarker. So I think you still have to look at the patient in front of you, and we would still provide aquapheresis for these patients. Again, in this in these settings, it actually just helped us decide for a couple of them to maybe hold off on aquapheresis near the end of the treatment. Seems like you did have NGAL in the past, and I'm not here to sell you any NGAL, but again, it is helpful to give you a sense of if a patient should continue dialytic therapy or not. What I would say is those 3 patients are probably like many patients you have, and you have a patient who's fluid overloaded, diuretic resistant. The NGAL is going to tell you to do it. It's really the fact that the patient's fluid overloaded and has acute kidney injury and won't respond to diuretics.
Do you have any protocol or pathways that will lead the ICU teams to make the trigger to call nephrology, in whether it's fluid overload or cardiorenal syndromes or post-op cardiac babies?
Yeah, we do. We have a very, very good relationship with our ICU teams. And depending on where we are in the ICU, which ICU and those different aspects, 10% volume accumulation in the NICU, in the cardiac ICU, or the PICU is almost always a trigger for consultation. Does not mean it is a trigger to start renal replacement therapy, but you have to have a really good reason why we were not consulted during that time at that point, because what we really try to avoid is the midnight come in and rescue this patient in pulmonary edema because we hadn't been paying attention for so long, or we thought diuretics were going to work, and we really don't have that anymore. So we have a number of pathways where it's not, it's not like Epic just says now you need to call nephrology, but volume accumulation is discussed in a percentage based on patient's weight or their I's and O's based on their weight. And we get called pretty early now. And I think all of our ICU teams have realized that, there used to be this fear that dialysis would cause acute kidney injury or worsen acute kidney injury. It is if you do it too quickly in terms of removing fluid too quickly in a really critically ill patient. But they've all realized that if you start earlier, patients tend to be on the therapy for a shorter period of time and they do better. And it's easier to prevent worsening volume accumulation. For instance, I almost never take net volume off for a patient in the first 24 hours that they go on CRT or aquapheresis. I really just try to keep them even because the intensive care folks have done fluid resuscitation and really just want to keep them stable and euvolemic from a day-to-day standpoint. So I would say it's all about volume for us. It's about, and that if the patient is not responding to diuretics, and what responding means doesn't mean that they put out 1 ml per kilo per hour of urine, right? Because at the end of this week, I might go drink 70 liters of beer. And if I'm a 70 kilo guy, 1 ml per kilo per hour of urine is not going to be enough. So can diuretics get you to where you need to be? Can it maintain the volume you want? Can it affect a negative fluid balance? And if it can't, then you have to escalate therapy. And if you wait too long, then it's going to get worse and worse for the patient. So we've moved from patients starting at around 12 to 15% volume accumulation to now we're at about 5% volume accumulation if you look at our most recent publications, because people understand we're not trying to remove excess fluid, we're just trying to prevent worsening volume overload. It's a long answer to what sounded like a pretty simple question, but we've thought about it a lot for the last 15 years.
Thank you. I appreciate it.
And now are most of you physicians, nurses? What are you all?
We have a combination of
All right. Yeah, so I think the important thing is who's ever at the bedside and is rounding, right? Because the nephrologist and nephrology team are the ones who have to, we rely on the consult, right? We can't just go in and say, oh, I see your patient's 15% volume accumulated, right? So the people at the bedside are like the ones who have to stand up for the patient and say, this patient, looks like the Michelin man. We've tried diuretics. It is time to really start and get the consult going. So I think that, if you have a good, collaboration with an intensivist and a nephrologist to come up with guidelines for the consult, doesn't mean every patient is going to start renal replacement therapy. That's a good place to start. And even in our most recent publication, where patients were really at high risk and had an elevated biomarker, only a third of those patients ended up ultimately going, and were 10% volume overloaded, only a third of those patients went on to kidney replacement therapy. But it shouldn't just be the doc of the day who's rounding. It really should be looking at your fluid accumulation, epidemiology in your program, in your different units. When have you been starting different dialytic therapies, and where can things be standardized? And that is just how you start, is coming up with a standard practice and an agreement and a guideline, and then you just you review it. I see that. I think Amy had a question. Yeah. How often do you use aqua for fluid overload, and how often do you add replacement fluid for clearance? So we use it in the PICU and the cardiac ICU for volume overload exclusively. We will use it with replacement fluid in our NICU, but understanding that that is all off-label. And, that was something that David Ashkenazi first proposed and works quite well using pre-dilutional fluid. But that's only going to give you enough clearance for, adequate clearance for smaller kids, because again, you can only go up to about 500, mils per hour. Remember that is if you're also wanting, if a patient's also getting TPN and IV fluids and other things and meds, you can't go above that 500 mils per hour. So you're really going to bump up against that limit. So it's really, you know, I would say pre-dilutional hemofiltration is really reserved for kids who are smaller, 5 kilos or less. Yep, in the NICU. Yep.
Anybody else have anything else? Well, thank you, Dr. Goldstein, for your time. We really appreciate it. This was very informative.
Great. Really nice to see you all there and have a great day. I bet the weather is really nice right now in Corpus Christi, so hope it's great.
It is.
Yep. All right. Take care.
Thank you so much, Dr. Goldstein.
All right. Bye.
Thank you. Bye.